Let's do a case, and Axel, I'll let you get the first shot at it, and then we'll get to pick on you a lot about what you chose to do. So let's make it a 60-year-old guy, has 3 liver metastases, primary in place. The central liver metastasis, the surgeon says, make it a little smaller, please. And then I think I'll do the resection and maybe do it all at once. So KRAS wild type, and let's say pan KRAS wild type. So what's your treatment of choice in this guy, 60-year-old, otherwise fit guy who's heard that you could cure him of his disease?
You know, that is very interesting. I mean, we see these patients, and you're shooting for a response rate, anatomical response, and you try to pull the structure, the tumor away from these critical structures. So let me throw out FOLFOXIRI. You know, FOLFOXIRI is one of the options you can use.
No biologic?
Oh, wait. Okay. You can use FOLFOXIRI probably if you really want to use this kitchen sink. The data are better for additional bevacizumab than for EGF receptor antibodies. There's some data with panitumumab and cetuximab emerging, but there's a lot of toxicity involved with that.
Let me be provocative. They live 2 hours from your center, and they have sled dogs and the whole bit. But what about CAPE-OX-IRI?
You know, I don't use capecitabine plus irinotecan because of overlapping toxicity. I personally ran trials way before I came here in Germany where we actually saw deleterious toxicities. I mean, mortality with capecitabine irinotecan. At the time, we really didn't understand exactly what was going on. I'd shy away from cape irinotecan. I think irinotecan is a great drug to be combined with 5-fluorouracil. FOLFIRI is a great treatment.
So FOLFOXIRI.
FOLFOXIRI is one of the options. You could, and this is where the new EPOCH study that Tony presented might have actually changed my approach a little bit, because this is one of the areas where I use cetuximab or panitumumab in first-line therapy, thinking that you have higher responses. Now you have FIRE3, no higher responses compared to Bev. And you have the new EPOCH study at least raising a flag, you know, that this might not be working well, at least with oxaliplatin, but no effect really with irinotecan. So I've actually shied away from using EGF receptor antibodies.
That'd be a spicy recipe too, I would think.
Yeah, it's interesting. In spite of the Salem data that Tony mentioned briefly.
Alan? What would you do on the other coast?
I'm not a big proponent of FOLFOXIRI, but I don't think it's often the case that we actually need a response. The surgeon says, well, of course they'd like it smaller, but in fact, does that really make a difference between resectable and not? Mm-hmm. So in that case, I might use the multi-drug combination. For the most part, I think patients are resectable or aren't when you see them. And the value of chemotherapy is to determine the biology of the disease, to see if the patient doesn't respond to chemotherapy. That's important as a prognostic factor. So I tend to be simpler with chemotherapy, which is I might use FOLFIRI alone. For example, I don't use Bev because using bevacizumab in the preoperative setting, you have to worry about stopping the Bev long enough before the surgery. If you have a major complication, you may have lost the opportunity. So I might go with FOLFIRI, or again, despite the data that we've heard about, my instincts in the past would have been FOLFIRI with an EGFR antibody.
So I get kind of stuck. Go ahead.
A couple of things. My concern about the combination of cytotoxic for someone who's going to go have maybe major liver resection, I don't know what's the impact of residual toxicity on the residual liver, you know, both irinotecan and oxaliplatin, of course, the duration. And going back to the FIRE3 data, although the intent to treat analysis was negative, and I have statistically being purist, I understand that. But if we take the patient who received treatment for evaluation, there is an advantage for. So if I make my patient at least make it to the first restaging and receive treatment, I still believe FOLFIRI plus cetuximab is the option for these patients.
But one point I'd make out is to limit the amount of chemotherapy, because much beyond, certainly FOLFIRI, more so than FOLFOX, is associated with chemotherapy-associated steatohepatitis. You don't want to make your surgeon, have a tougher time and with major complications associated with it. So, no more than 3 or 4 cycles of FOLFIRI before you make.
Quite rapidly whether or not you'll
right. If there's not a response immediately, you're not likely to get a response with more chemotherapy.
The great state of Ohio. What do you all do?
So I think I'm going to agree and disagree with a lot of what was said. Well, first of all, I do agree with Axel that EGFR inhibitors may, at this point of time with the data we have, may not play an important role, even with the clearly resectable. I think we often confuse just response rate with benefit for those patients. In fact, I would even argue that a 3-drug with bevacizumab, if we look at the TRIBE study, when they looked at their analysis on the liver-limited disease, and part of it was pre-planned, then even with the patients who were full FOLFIRI bevacizumab was given versus FOLFIRI bevacizumab, the R0 resection rate was exactly the same. So I agree with Alan on that standpoint that most of what we're doing is really we're testing the biology of the disease. Oftentimes we get a little response, but the most important predictor of how well those patients do is the R0 resection rate, not the resection rate, the R0 resection rate. And so for an R0 resection rate, FOLFIRI, Bev, seem to be, at least from my standpoint, most logical. A lot of the other regimens are not, I think, are probably equally good, but unnecessary.
So I don't get the irinotecan, guys. I mean, so you're doing two things here. You're giving adjuvant therapy and you're making tumors shrink. Now, we could argue Nordlinger is negative in oxaliplatin in the perioperative setting, but irinotecan doesn't work in the adjuvant setting. Cetuximab doesn't, Bev doesn't. So why aren't we just giving FOLFOX?
But FOLFOX Bev, which is, of course, what most people use in these patients, there's no advantage to the Bev to FOLFOX, really.
Other than a 30%, 20% increase in response rate if we believe the cross-trial comparisons.
Right. So I think the truth is we don't know which the right treatment is.
But I'm with you on that, John, because I use the preoperative data to give postoperative therapy. So if you then look at the only data set we have really is the early EPOCH study, which is FOLFOX.